Hello and good afternoon to everyone. Thank you so much for joining us today. My name is Jamie Singletary, and I am the Director of Family and Alumni Programming for Within Health. And I am so happy to welcome you all to the December presentation of our Within Health Education series. Today, we are going to be getting a presentation from the lovely Chrissy Stockert. But before she begins, I would like to go over just a few housekeeping things. This is a CE Go presentation, and so at the completion of this presentation, you all will receive an evaluation. Can I have you mute, please? Thank you. As I was saying, at the completion of this presentation, you all are going to receive an evaluation. The evaluation will come to the email that you registered in. So if you're logging on from a different device, don't worry about it. We will just email you the evaluation to the device that you registered under. Also, that is how you are going to get your CE certificate. So once you complete the survey, you will then be given a link that will allow you to download your CE certificate. Also, this presentation is going to be recorded. You will also navigate the recording through your CE Go dashboard. So we will have the recording there and you can get to it through your dashboard. If for some reason there's a technology issue and you have to go onto a different device, just please email me utilizing the chat option, and I will see to it that you get your certificate. Speaking of the chat feature, that is also where you can place any questions that you may have for Chrissy. We will have question and answer at the completion of her presentation. So without further ado, it is my pleasure to introduce my friend, my colleague, Chrissy Stockert, who is the Director of Health Services and Quality Assurance here at Within Health. And today she is going to be speaking to you all on how medical complications of eating disorders present in treatment. And I will turn it over to you, Chrissy.
Hi, everyone. Thank you so much for having me today. So I'm going to take a second and share my screen with all of you. Make sure I'm sharing the right one. Okay. All right. Can everybody see that? I'm dropping a couple people.
Yes.
Yeah. Thank you. Awesome. Thank you. All right, so today, like Jamie said, we are going to be talking about how the medical complications of eating disorders present in treatment. So one of the things that we know about eating disorders is that when it comes to medical complications, every single body system can be affected. So we don't have time in an hour to go through all of the different complications that could possibly present. So I wanted to look at some of the most common things that we see when clients come into treatment at a non-inpatient level of care. When we're talking about complications of eating, can you guys mute yourself if you're not muted?
Brought in what?
Thank you. So one of the things to remember when we're talking about eating disorders and their complications is it always goes back to energy in and energy out. If energy in is not sufficient, energy out is going to start to decrease over time so that the body can compensate for the lack of energy coming in. The other two things that I always like to start with is that the majority of medical complications that we talk about are universal to eating disorders in general. There are some that may be more related to one behavior versus another, but in general, when we're talking about eating disorders, there is malnourishment involved, and the complications that we see when someone comes into treatment are very similar across the spectrum of eating disorders. And the last thing I'll say before I jump into things is that the body is incredible. With very few exceptions, things can be completely restored. It is not that once you have a complication, you're doomed to have it forever. If somebody recovers fully from their eating disorder, with very few exceptions, there can be full restoration of the body. So the first thing that we're going to go ahead and we're going to look at is we're going to take a look at the blood. And there are changes in lab values. And so the thing to remember is that our blood wants to stay stable. And the body is going to fight and fight and fight to keep it that way. And so labs will remain normal for a very long time. They're going to be fine, fine, fine until they are not fine. And when they are not fine, they're really not fine. And we know that the body is going through something really difficult. And so one of the things that we'll see very commonly is we see changes in sodium. And typically what we're going to see is something called hyponatremia. So hypo meaning low, natremia meaning sodium. If we see sodium that is too high or too low, it's really dangerous. You can see things like headache, confusion, loss of energy, drowsiness, or restlessness, muscle weakness, but most commonly or most seriously, we see seizures and coma, and it can lead to death. When we are seeing it in treatment, typically this is something that's going to be caused by a behavior called water loading. So if you imagine having a cup of water and you add a teaspoon of salt to it, that's going to be pretty salty water. When we're talking about sodium, it would be virtually impossible to eat so much sodium that you're dumping more and more sodium into that same cup of water. But what's not impossible is if I were to dilute that 1 teaspoon of sodium with a lot more water. So if somebody is engaging in that behavior of water loading, it's imagine that they poured 1 teaspoon of water or sodium into a cup of water, and then they drank a whole lot more water, that sodium would become very diluted. And that's what happens with eating disorders. If someone engages in that behavior of water loading, they dilute their blood so much that their sodium level drops. And you can see all of these complications start to occur as a result of that. So the treatment for it is going to be restricting someone's fluid. It sounds very limiting when we say something like fluid restriction, but really what we're talking about is we're going to say you're going to drink 1 to 2 liters of fluid a day. It's actually kind of a normal amount of water, but for someone who may have been drinking 8 to 10 liters of water a day, it's going to feel like pretty severe restriction. One of the things that's really nice about it, though, is that once the sodium level normalizes, unless a behavior starts again, it's not going to become abnormal again unless there is some other physiological process going on, but it's not going to be directly related to water loading as a result of their eating disorder. So another electrolyte that we're always wanting to watch is we're wanting to watch potassium. So we have a normal potassium somewhere between 3.5 and 5 when we're checking labs. And potassium too high or too low is dangerous. So again, symptoms that you can see, things like tiredness, muscle weakness or spasms, tingling and numbness. Most dangerously, it can lead to heart palpitations, cardiac arrhythmias, and death. Now, this is one electrolyte that can be affected by any type of eating disorder, but is most affected by someone who is engaging in purging behaviors. Purging, though, via any means. We're talking about purging via vomiting, purging via laxatives, and purging via diuretics. All of those can relate to abnormalities in potassium. When potassium is excreted, we typically see something called hypokalemia. Again, hypo meaning low, kalemia meaning potassium. And it can be treated by either supplementation with potassium or stopping of the behaviors. And similar to sodium, if somebody stops engaging in the behavior, we're not going to see that value become abnormal again, unless maybe they start to engage in that behavior again. So we watch labs sometimes to know whether we think someone may or may not be engaging in an eating disorder behavior. Now, glucose is another one that we can see with abnormalities. And this is one that can be interesting because you can see low glucose, hypoglycemia, happen before someone comes into treatment. And it's actually something that we can see as part of the refeeding process. So when someone has a normal fasting glucose, meaning they haven't eaten anything in quite a few hours, you're going to see that number vary somewhere between 70 and 100. And then commonly what we see is that when someone eats something, that glucose is going to be absorbed into their bloodstream. Their glucose number will get much higher. Insulin is released, and then little by little over time, it's going to come back down to that normal fasting range. We see a phenomenon in eating disorders that it's called postprandial hypoglycemia. So post meaning after, prandial meaning eating, hypo, low, glycemia, sugar. And so here's what ends up happening. Someone with an eating disorder starts to eat again. There's this reintroduction of food. And when somebody does not have an eating disorder, they have stores of glycogen in their body. So tuck that away for a second. We're going to come back to that in a minute. So someone with an eating disorder eats something. That glucose is absorbed into their bloodstream. Their pancreas says, ooh, time to release insulin. Out comes insulin into the bloodstream. And what insulin does is it works at the cellular level and tells glucose to go into the cells where it can actually act as energy for our body. Now, when someone hasn't been eating for a long time, their body may not know actually how much insulin to release. And it might say, oh, thank you for feeding me. And it dumps out insulin, but it's way too much insulin. And all of the sugar from the bloodstream goes flying into the cells. And now we have a level of glucose in the bloodstream that's well below that 70 to 100 range, only this person has just eaten. So they should have a glucose level that's maybe 130, 140, 150, and instead we see something that's maybe 68 or 58. And it can be very scary. It can be very uncomfortable. So if anyone has ever experienced hypoglycemia, you know that there's often something associated with it called the impending sense of doom. You don't like it, you don't feel good, you know something is very wrong. Sometimes you have a severe and sudden onset of a headache. I can tell you a lot of patients will come up to me and say, oh my gosh, my head hurts so badly right now. And they don't know what's going on. And I'll say, well, give me your finger. This is when I worked in a residential. Give me your finger. And we would check their glucose. And sure enough, their glucose was really low. They can also have a cold sweat. They can shake. They can get very anxious and irritable, which can also be difficult to distinguish in a patient with an eating disorder because they tend to be anxious to begin with. They may experience dizziness on a regular basis. And so we always have to be wondering in the back of our minds, is glucose affected right now? Now, I told you to tuck away this idea of stores of sugar. So in a person who doesn't have an eating disorder, we have a tremendous amount of glucose stored in the form of glycogen in our liver. So if I were to eat something, I don't have an eating disorder, that glucose is absorbed into my bloodstream and my body releases insulin, but it's too much. And that level in my bloodstream starts to get a little bit low. My pancreas would release another hormone called glucagon. And that glucagon tells my body and my liver, release the stores of sugar. And out comes a lot of sugar that boosts that level right back up in my bloodstream. And I keep going, walking and talking, never knowing that anything has happened. But someone who has an eating disorder doesn't have those stores of sugar. So glucagon is released in their body, tells their body, release the stores of sugar, and absolutely nothing happens. And they start to feel worse and worse and worse. When hypoglycemia is very severe, it can end up leading to confusion, loss of coordination, blurry vision, coma, seizures, and death. Typically, what we are going to see in treatment is more so the racing heart, the shaking, the anxiety, and irritability. And that's going to be a trigger for us to check what's going on with sugar levels. The thing with eating disorders, though, is that the treatment for it is to have something with sugar in it, which can be very scary for someone who has an eating disorder. But we try to work with them to get them to have something with glucose. And typically about 10 minutes later, they're going to feel all better. And the last one that I want to talk about when we're talking about the blood is I want to talk about phosphorus. So phosphorus is an element that we have in our bodies, and we have tremendous amounts of it. And if anybody can go back to, I know I'm going to have you channel the olden days of biology and chemistry or anatomy or one of those classes that you took, and you remember about the energy packets of the body called ATP. That P at the end of ATP is phosphorus, adenosine triphosphate. And that phosphorus is the energy packet of the body. And I'll share with you how I remember it, because it was in a nursing book that I had, that it almost worked like a hook. So that P at the end of phosphorus acted like a hook, and it's what causes effective muscle contraction. So when someone has an eating disorder and they are in a negative state of energy, their body is going to use up that phosphorus that they have in huge storages, and the natural amount that they have is going to be lower, but it's still going to be normal for what they need. There is an element of refeeding syndrome called refeeding hypophosphatemia that happens with the reintroduction of food, when all of a sudden the body is given a lot more energy, and it can use this energy, and it's going to start to create tremendous amounts of ATP. It's saying, yay, you're feeding me, you're giving me energy. And it wants to create all of this energy, only then it runs out of phosphorus and it can't create the ATP. And so the body is going to start stealing it from different places. And one of the places that it's going to steal that phosphorus that it wants so badly is from the muscle that needs to contract effectively tens of thousands of times a day, our heart. So if phosphorus is stolen from the heart, it is going to end up leading to ineffective muscle contraction, which is also called congestive heart failure. And that's something that can lead to death associated directly with the reintroduction of food. So when we have clients who come into treatment with us, we are going to be checking their labs pretty frequently, because one of the things we want to check for is to make sure that that phosphorus level remains normal. The risk of hypophosphatemia gets higher and higher for the first few weeks of treatment. And then after about a month, that risk drops to almost nothing. I have seen it happen a little bit later in treatment, but typically we see it early on in those first couple of weeks. And then we don't have to check that phosphorus level quite so closely, because the body will have restored those phosphorus levels that they need. So leading directly from one element that can affect the heart into the heart itself, we can actually see quite a few cardiovascular changes when somebody has an eating disorder. It takes a huge amount of energy for the heart to beat and for the vasculature that's around our body to maintain itself. And so when somebody is again in that negative energy state, everything is going to start to slow down, and we end up seeing changes in the cardiovascular system. So one of the things that we're going to see is something called bradycardia. So brady is slow, cardia is heart. So we have a normal resting heart rate of somewhere between 60 and 100 beats per minute. And so that is a number that you want to see when somebody has been lying down for maybe 10 minutes or so, really relaxing, not worrying about white coat syndrome, being at the doctor, and maybe they have high anxiety and they're going to see a little bit of a higher heart rate, but a resting heart rate should be somewhere between 60 and 100 beats per minute. When the heart is starved, though, it's going to try to conserve energy, and we start to see that resting heart rate get lower and lower. So bradycardia is defined by a heart rate that's lower than 60 beats per minute. One of the things, though, that ends up happening is that a lot of people with eating disorders have other things that, or other, I don't even want to say other, they have behaviors that might reinforce that this is a good thing, especially when it comes to things like exercising. So when somebody with an eating disorder goes to the doctor, what we often see is that they will omit the fact that they have an eating disorder, but will say that they, for example, run 5 miles a day. It's not a lie. They are doing that, but they don't say, and also I have a pretty severe eating disorder. And so then what ends up happening is the doctor will say, congratulations, you have such an athletic heart. And one of the questions that we want to one of the things that we want to reinforce with our patients is actually, you don't have such an athletic heart. Your heart is not beating so efficiently that it can It can perfuse your body so efficiently that it doesn't need to beat as much. It's actually saying, how little do I have to beat to keep you alive? And those are two very different things. So with your patients, when you're talking to them, if you're wanting to try to reinforce that bradycardia is not necessarily a good thing, that's the question that we want to ask them. Is your heart really that efficient, or are you trying to beat so little to keep you alive? Another thing that we see in the cardiovascular system is something called orthostatic hypotension. So that's when we see a change in blood pressure when someone goes from sitting to standing. And typically what you're going to see is a drop in blood pressure of the top number, so the systolic blood pressure, and or you may see a rise in heart rate from sitting to standing of more than 20 beats per minute. When somebody goes from sitting to standing, you want your body to be able to compensate immediately, because if I stand up, gravity is going to take over and blood is going to fall, because that's what gravity does. But there is a very important organ in our body that needs that blood all the time, and it's our brain. If our brain is not getting blood, it's not getting oxygen and nutrients. And so if somebody stands up and their blood vessels can't tighten up immediately, that blood is not going to keep being pushed upwards. It's going to actually fall, and that's going to cause a tremendous amount of dizziness. So when someone has an eating disorder and their blood pressure drops when they've gone from sitting to standing, it means that their body could not compensate for that change in posture, and that blood is actually going to fall, and they're typically going to be experiencing a lot of dizziness. And we've all probably experienced it at some point in our life. I know that there are times when I might be squatting down and I stand up and I get that head rush and I'm like, whoa, I just stood up way too fast. But imagine if that happened to you all day, every day, and it didn't last for 5 seconds, it lasted for 2 or 3 minutes. It can end up leading to falls, fainting, and generally feeling very, very poor. And so it's something that we want to be watching out for. And one of the reasons that we often ask our patients, do you feel dizzy when you stand up? And I can tell you anecdotally that there are a lot of times that I have patients who will experience that drop in blood pressure and don't necessarily feel any dizziness at all. And there are a lot of times that I will have patients whose blood pressure stays perfectly normal when they go from sitting to standing, and they feel a lot of dizziness. And so this is one of those cases where we have a definition of what orthostatic hypotension is, but it's also really important to ask your patients about symptoms that they're actually experiencing rather than just looking at a number. We treat a person and not necessarily a number. And one of the other things that we see in our patients is acrocyanosis. So acrocyanosis is something that's very normal in a newborn baby. And if anyone has ever had a baby or knows someone who had a baby, they may talk about something called an APGAR score. An APGAR score is how healthy that baby was when they were first born, and they do it at 1 minute and then again at either 5 or 10 minutes. And the A of the APGAR score is acrocyanosis, because when a baby is first born, they very often have bright red, almost purplish looking hands and feet and extremities. And basically what's happened is that those extremities circulation has been shunted away from them to keep it all right in the core. It is not normal in someone who is not an infant. But we see this very, very commonly in eating disorders. You'll see people who have very purple hands, same thing in their feet, they get very purple. And what's happening is their circulation is not effectively working in those extremities. And so the way that I like to describe this is I ask everybody, and you can do it right now if you want to, you can take a look at either your fingernails or the pad of your finger, and you push down on it. It should have been a normal color. You push down on it, it kind of turns white, and then you let go of it, and it should turn back to its normal color. And that should happen in about 3 seconds. And that means that your circulation is normal, because when we think about circulation, our heart and our circulatory system is one big circle. The pressure that pushes blood out of our heart is what pushes it into our extremities. And that same pressure is what pushes it back into our veins so it can come back to our heart, all in one big loop. When you push down on your finger and it turns white, you have manually pushed the blood back into the veins. And now you want to see how long does it take to actually recirculate and refill those capillary beds. And you want that number to be less than 3 seconds. In our eating disorder patients, what we often see is that that number is not 3 seconds, not 5 seconds, but maybe 6, 7, 8, 10, 12 seconds. That capillary refill is not working very well. And what ends up happening is blood pools in the extremities because there's not enough pressure pushing out of the heart. So it pools in the extremities before pushing back to the veins. And that's where that deep red color comes from. And essentially, it's, again, the body's way of saying, I want to keep blood shunted away from these extremities, keep it right here in my vital organs, because my heart and my spleen and my liver and my stomach are all more important than maybe the growth of my fingernails. So it's a very intentional process that happens. And it's one of the things that with recovery, we see also gets much better with time. All right. So the next system that we see affected by eating disorders is the GI system. Oh, the GI system. Everything slows down. So the thing to remember in a state of malnourishment, that GI system wants to hold on to everything for as long as it can. This can, though, end up leading to all kinds of different things that happen in that GI system because everything is slowing down. So if we work from top to bottom, one of the first things that we see is acid reflux. So in a normal eating pattern, somebody eats, they chew, they swallow, and then food goes from their esophagus through what's called the esophageal sphincter and into the stomach. And that esophageal sphincter is supposed to be a very, very tight seal because our stomach is full of hydrochloric acid. And that's a major step in digestion. But our stomach is built to hold it, and our esophagus is not built to hold that hydrochloric acid. And so when somebody is malnourished, or especially when we see somebody consistently engaging in purging via vomiting, that sphincter can actually loosen up and it becomes more of a hole than a very tight seal. And that gives acid a free flow up and down. And it can lead to inflammation of the esophagus, narrowing of the esophagus from scar tissue. It can lead to Barrett's esophagus, which is a precancerous change that can lead to esophageal cancer. All of those are things that we can see when someone has consistent acid reflux. That's not something that's specific to eating disorders. That can be caused by anybody who has acid reflux, but it's a very common thing that we see in patients who have eating disorders. Another thing that we see very often in eating disorders is gastroparesis, which basically means the slowing down of the GI system. This can lead to nausea, vomiting, abdominal pain, bloating, constant feeling of fullness, people saying, I never feel hungry, acid reflux. Changes in blood sugar levels are another thing that we can see when that gastroparesis is happening, because food is digesting differently. And if you think about why that would happen, if the body doesn't know when to expect appropriate nutrition, it wants to hold on to everything for as long as it possibly can. And so if it says, you're not going to feed me, I want to suck every nutrient out of whatever pieces you are going to give me, and all of it slows down, which can then lead to constipation. Constipation is something that's very tricky in people with eating disorders. When we look at the definition of constipation, we're talking about a decrease in bowel movement frequency to fewer than 3 times a week. People with eating disorders, though, typically have a desire to feel empty. And so when you talk to someone with an eating disorder and they say, I haven't had a bowel movement in 9 days, and you think, oh my gosh, that would be horrible. Couldn't imagine not having a bowel movement for 9 days. And then you start to talk to them about it. Well, you've had absolutely nothing. I say, well, I had some, but it wasn't a good one, or it wasn't a full one. Sometimes we have to talk to them about what constitutes constipation and what may be their body simply readjusting to something called fullness. That being said, constipation is a very real thing that is experienced because of the gastroparesis. That can then lead to, the longer something sits in your intestines, the more water is absorbed from it, and it can lead to very hard stool. It can lead to a lot of straining. And very often, people then want to do something about it and may start to take laxatives. One of the things that we will not recommend is that someone use a stimulant laxative. There are different types of laxatives that you can buy. Things like Senecot or X-Lax, those are stimulating laxatives. They work at the nerve level in the colon. And they can end up burning out the colon to the point where they become habit forming and you become dependent on them and need more and more of them to elicit the same effect. And some people may come to us taking several hundred of them a day just to elicit a bowel movement. We recommend that people use osmotic laxatives. So things like Miralax or milk of magnesia, because what those do is they draw water into the colon to create bulk. And that bulk is what helps to move things along and create peristalsis, which is the contraction of that smooth muscle to elicit a bowel movement. But then, we're also dealing with the idea that when somebody starts taking something like Miralax, feeling like, what if I stop and I can't ever have a bowel movement again? And so we can work through then what that would be like, because at the end of the day, what we know is that when the body is fully restored, it should be able to have normal bowel movements on its own. And that's something that we see all the time. So then we have another whole system that we see a lot of different effects happen with the endocrine system. So endocrine system is where all of our hormones come from. And the endocrine system is one of the biggest pieces that helps our body survive when there is that decrease in energy. So one of the things that we see is something called euthyroid sick syndrome, which is a mouthful to talk about. So here's what normally happens in a typical functioning thyroid. We have in our brain a tiny little gland that releases something called TSH. TSH is thyroid stimulating hormone, and it goes from our brain to our thyroid, which is right here in our throat. Hormone. If someone has a non-eating disordered, high functioning thyroid, it's called hyperthyroidism. The thyroid is releasing way too much hormone. And so what you see is TSH coming from the brain is very low. It's saying, whoa, 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 don't release thyroid hormone. You have too much of it. And the thyroid's releasing too much. And so you have a low TSH and a high T3 or T4. You can also see the opposite happen. Somebody doesn't have enough thyroid hormone. Those hormones are low. And you see a high TSH because the brain is saying, hey, thyroid, why aren't you releasing enough hormone? Release more, so that TSH level is very high and T3 and T4 are low. In an eating disorder, what we often see is a low T3 or T4 and a normal TSH, because the thyroid is what drives the metabolism of the body. Should say that also. Metabolism has then slowed down. So we see that low value of the T3 and the T4, and you would expect to see a high TSH because the body is going to be saying, why are you not producing enough thyroid hormone? And what you end up seeing in someone with an eating disorder is a perfectly normal TSH. The body is saying, you are not giving me enough energy. I don't want a normal functioning thyroid right now. I want it to be low and slow. And that can make somebody have low energy. It can cause depression. It can cause all kinds of things, but the body does not want it to be normal because it's not receiving enough energy. When someone starts to eat consistently for a while, what you end up seeing with no medical intervention whatsoever is that TSH remains normal and the T3 and T4 values pop right back up to normal. The other thing that we see is we see changes in sex hormones. So if we're talking about women, estrogen and progesterone essentially stop being produced. In men, you see testosterone levels that decrease significantly. And if we were to look on an ultrasound at the uterus and the ovaries, they basically shrink, they involute, and they look prepubescent or postmenopausal. And one of the very common things that we see in women is something called amenorrhea, or an absence of a woman getting her period. But one of the things that I want to add here is that this is not something that happens all the time. And it is no longer part of the diagnostic criteria for an eating disorder, because there are a lot of people who continue to get their period. And there are some who never lose their period ever, regardless of where they are on the weight spectrum. And it's important to know that, because for someone with an eating disorder, it can feel very invalidating if they say, see, I'm not even sick enough to have lost my period. I kept getting it this whole time. It's not a definition of how sick you are. It's something that can happen as a result of the eating disorder, but it is not something that happens universally. If it is something that happens to someone with an eating disorder, what we know is that typically the period will return when someone is at about 90% of their expected body weight. I did not say their ideal body weight, I said their expected body weight, because expected body weight and ideal body weight can be two very different things. One of the things that we often see, though, is that people with amenorrhea are looking to where do they get their period, and then they say, I got my period, everything is fine, I'm done. I don't need to weight restore anymore. But what I just said is that they will get their period around 90% of their expected body weight. There is still 10% of weight restoration that may be left. And it's really important to make sure that somebody knows that when they get their period back, they are not necessarily done weight restoring. They may still have a significant number left to gain. And then the last thing that I want to talk about is the bones. When someone has an eating disorder, we know that bones are affected. Thing though is that we just don't know when they are going to be affected. So, anyone else hear that echo? Yeah, okay, it's good. So when the way that bones normally work, we are always creating new bone. We are depositing bone and we are recalling bone. And yes, every 10 years, you have an entirely new skeleton, because we don't want our bones to be old. We need them to be fresh and strong so that they don't break. When we are young, we are depositing more than we are recalling so that our bones can be getting bigger and thicker and stronger. Peak bone formation happens during puberty. And then between 25 and 30 years old, we reach a state of equality. So we are depositing bone and we are recalling bone in equal amounts. Our bones are their biggest, thickest, and strongest. Postmenopausally, Women are often recalling more bone than they are depositing, which is why postmenopausal women often get DEXA scans to check and see if they have bone loss. And the reason that it happens specifically in postmenopausal women, though it does happen in men as well, is that those same hormones that drive our period are the hormones that drive bone formation. And if those hormones are gone, which is what happens postmenopausally, that's what contributes to the bone loss. So if our patients with eating disorders also experience that absence of menses, those hormones are not circulating throughout their body anymore, there is a very, very high likelihood that they are also experiencing bone loss at the same time. And so the way that it's checked is through a DEXA scan. We're measuring the density of those bones, and it's done with standard deviations and Z-scores and T-scores, depending on your age. And there are two different classifications that somebody can have. They can have a classification of osteopenia, which means they have some bone loss, or osteoporosis, which has always meant irreversible bone loss. Now in adolescence, it has actually changed, and they are not given a diagnosis of osteopenia or osteoporosis anymore. They are given a reading that will often say something like less than expected bone density, because when someone is very young, there is so much time to make up some of what may have been lost that they don't want to actually give that diagnosis anymore. So that diagnosis is now saved for people who are a little bit older, more in that 25 plus age range. 30% of people with anorexia have osteoporosis, and 90% have some bone loss. We had always said that osteoporosis is irreversible, but now what we are finding is that because there are new studies that are being done on specifically this population rather than postmenopausal women, that there is actually the ability to make up some bone. But the older you are, the harder it is to actually make up that bone, which is why, especially for our younger population, we want to be emphasizing the need to fully recover, because full recovery is the best hope that someone has to make up some of that bone that may have been lost. So I'll finish with this. Eating disorders can have a devastating effect on the body, but with recovery, restoration is possible. So, and then I have a bunch of references. So what I want to do now is I want to leave some time to open up for questions. So Jamie, I know that you had been manning that.
Yes.
Okay.
We actually have two questions in the chat. The first question is from Savannah, and the question reads, can you speak to how we assess what the normal ranges are for these blood labs? I see you put the normal ranges in your slides, but it seems that every lab or doctor's office reports a different quote unquote normal range, and the patient might have low or high level according to one office's normal range, but not another's.
Yeah, and that's actually something that's going to be different based on every lab. So every lab is going to have their normal range, and they're going to vary ever so slightly from one to another. So you may have one lab that says normal sodium is 135 to 145, and another one that says it's 136 to 146. It just is what it is. And so we're going to look at it, and we're going to look at trends, and we're going to know, it's one thing if somebody's sodium level is 135 and in that lab it's 136 to 146 is normal versus somebody having a 128. And so there are differences and variations in what you would do and how urgently you would treat something. But the ranges should be pretty similar from lab to lab.
The next question comes from Ashley. What do you recommend for someone who is bothered by acid reflux while gaining weight? Are over-the-counter remedies appropriate, or any resources in general you recommend for GI issues for folks in recovery, such as websites, pamphlets, or blogs?
Yeah, so thank you, Ashley. That's a great question. Acid reflux is something that can happen as a physiological response to that esophageal sphincter that I was talking about. And it's something that we can see in that recovery process when somebody is trying to weight restore. One of the things that I tell people often is weight restoration hurts. It is uncomfortable enough that you won't typically do it on your own, which is why higher levels of care even exist, because it is that uncomfortable. And one of the things that can be incredibly uncomfortable, in addition to simple fullness that feels extremely painful, is acid reflux. And so there are a lot of different things that you can do. So if somebody is, not wanting to take medication, it can be something as simple as like peppermint tea, hot water bottles, comfort measures that might feel better to them. A first line of defense can always be some good old fashioned Tums. The one thing I will say with that is make sure that this is someone who is hydrating, because Tums are calcium carbonate. And if you're not hydrating well, then you're going to end up with another issue, which is kidney stones. Don't want to go there. And then if it's somebody who's using, let's say they're using Tums, but they're using it 5 times a day, every single day, there's probably something a little bit more chronic going on. Always they're going to want to be checking with their physician. So their physician is the one who's actually going to prescribe some of these remedies to them, but there are then more longer acting medications that can be helpful. So really there's 2 different types. There's something called H2 blockers, which are things like Pepcid and Tagmint. And then there are something called PPI, proton pump inhibitors. And that's things like Prilosec or Protonix or Nexium. And those, typically last for a full 24 hours. You take them every single day, but they are not always needed long term. You take them for the 5 weeks that you need it, and then you can wean yourself off of it. So those are some different things that you can do for some of those GI symptoms. But I always like to tell people and just preface them with refeeding hurts.
We have another question. This participant was not able to be at the very beginning of the talk. So the question is, could you please talk about reactive hypoglycemia in people with anorexia, the causes, and how to treat it?
Okay, yes, so we can hop back to that for just a second. So again, typical course of action. You eat something, glucose goes, the food goes into your stomach, it gets digested, and it's absorbed into the bloodstream. When it's absorbed into the bloodstream, your glucose level should go up, which triggers your pancreas to say, release insulin. Out comes the insulin, which works at the cellular level, that tells the insulin, the sugar, to go into the cells where it can be used for energy. Now someone has an eating disorder. They have not been eating consistently for a long time. They start to eat. So they eat something, that glucose is absorbed, and before the body can even get a glucose level that gets a little bit higher, the body says, thank you so much for feeding me. Pancreas, release insulin. Whoosh, out it comes in huge amounts and goes flying into the cells. And now all of that glucose is in the cells and it's not in the bloodstream anymore. And poof, those levels of glucose in the bloodstream crash. And that's when you end up with reactive hypoglycemia. So you've eaten something, and rather than it going up, you see that glucose level that goes down. The body in someone with an eating disorder also doesn't have stores of sugar to help combat that. So if that were to happen to me, my body would release glucagon, which tells my liver and my cells, release my stores of sugar. Out it comes, and I keep walking and talking, never knowing the difference at all. Glucagon is released in someone with an eating disorder. They don't have those stores of sugar, so nothing happens. And that glucose level keeps going down, down, down. The treatment for it is typically twofold. So in the beginning, I mentioned you want them to have something with sugar in it. It's got to be a fast-acting sugar. So orange juice, any kind of juice is typically going to be the best thing. There are glucose tabs that people can take, but I always think that when someone is recovering from an eating disorder, food is medicine. And I would rather that they have something with juice than they take like a chewable pill. So they have something with a high amount of glucose to boost that level back up to normal. But what's going to happen if you only do that is it's going to boost that level of glucose up and then it's going to crash again. And so you have to pair that with something else, typically a fat and or a protein, because those all digest at different rates and become glucose at different points. And so it's going to kick up that glucose level back to normal and help keep it steady. The other thing that I've seen done a lot when someone has very consistent reactive hypoglycemia, and it seems to just happen all the time, is don't make the body think too hard. Keep every meal and snack as close to the same thing as possible so that it knows that it's going to release the same amount of insulin every time. So instead of, for example, having a lunch that's 800 calories and an afternoon snack that's 300, you're going to want to make them 500 and 600 so that they're about the same. So the body knows it's going to release the same amount of insulin pretty much every time it eats.
We have another question, and it says, I've seen patients in higher weights with high levels of glucose with severe histories of restriction. Doctor says it's diabetes, but I've heard this can happen in severe restriction due to insulin sensitivity. Is this the case?
So I have seen insulin sensitivity happen. Insulin resistance is another thing that we can talk about, which is basically when cells become less receptive to the insulin that is there. There are times when this is transient, and there are times when it may stick. Now, insulin resistance is not a diagnosis of diabetes. A diagnosis of diabetes comes when glucose levels remain at a certain level and A1C remains at certain levels. But insulin resistance is something that we can see happen. And there are different things that you can do for it. So, I know that the typical answer that that a doctor is going to give, especially if you go see, your PCP or an endocrinologist, is they're going to say lose weight. When we see that in somebody who's in a larger body. When I worked at a previous facility, there was a small study that was done on people in larger bodies and we did, different labs on them throughout the course of treatment. And what was found is that there were two things that had the biggest effect on their insulin levels, A1C levels, and glucose levels. And that was one, normalizing eating patterns. So we did not restrict any food from their diet. We increased some variety. And number two was gentle movement. Those were the two things that made a difference. And across the board, 100% of them had a decrease in their A1C, their glucose, their fasting insulin, their cholesterol, and very few of them had any change in their weight whatsoever. I'm not sure if I answered the question, but that's what I got right now.
The next one says, if a patient is low weight but strongly increasing intake with supervision from weekly doctor's appointments, weight isn't increasing much despite increased intake and lack of purging, how do we determine if and when a higher level of care is needed?
Whew. That's a tough one. And I'll say that, it's a multidisciplinary decision, I think. That's not something that I would say, yes, I can answer that hands down. Yes, I know that this is when a higher level of care would be needed. What I can say historically is that if someone is eating very high amounts of food or is reporting to, and the weight isn't changing, there is also a very high probability that may not be a truthful answer. That may be an eating disorder talking. And that may be indicative of a need for a higher level of care. There are also times when people need, because of hypermetabolism, which is another thing that can happen with eating disorders, that metabolism just is so thankful that it's getting food now that it needs tremendous amounts of energy. And we're talking sometimes, 5,000 to 6,000 calories a day in order for someone to gain weight. that, again, refeeding is painful. That can be so painful that somebody may not be able to do it at an outpatient level, because you need someone on top of you 24 hours a day saying, here's your meal, here's your meal, here's your snack, here's your snack, to actually be able to get that food in.
The next question we have, it says, wondering if you check leptin levels of your patients. I'm curious if you take it into consideration to gauge nutritional status or check as patients' weight restore.
That is not something that we have been doing, but something that I have been looking at a little bit. So my answer right now is no, we have not been, but I know that that is something that is now being checked frequently.
You're also getting a lot of love in the chat, Chrissy. Everyone is talking about how amazing and informative this presentation has been. I know Savannah had a hand up. Savannah, did we get your question answered for you?
You did, but I actually had another one, if that's okay.
Sure.
Sure.
So you did such an amazing job at describing all the specific needs of the body when it comes to energy intake. I'm wondering, for those patients who have a harder time understanding why actual weight needs to go up, could you explain medically why it's important to physically have more weight on the body? Like, even if they think they're eating enough energy, but they want to keep their weight low and have their energy high somehow, like, why wouldn't that work?
I wish I had a good answer for that. And I feel like any answer that I give anyone ever is never the answer that they're looking for. And really the way that I approach it with them is it's not sustainable. So when I hear a comment like that, I can hear that that's driven by their eating disorder. I want to be recovered, but I don't want to gain weight, but I don't want my body to change, but I don't want to change anything. I just don't want to have this eating disorder anymore. And when that's coming from an eating disordered place, I know that if they don't continue to gain weight, boom, it's going to start to restrict again. It's going to go right back down. It's not going to remain sustainable, because then it's not going to be, why can't I just maintain this? It's going to be, well, I could lose 1 pound and that would be okay. And so really, it's a matter of, when does that brain chemistry start to change, and it becomes less about the number and more about, I want to be well, I want to be recovered. If my body happens to change in that process, I may not love it, but I'll learn to manage it. And that's how because you're not going to have a good answer for it. It's because there's going to be a rebuttal to everything.
Mm-hmm. So almost like, if they're trying to just keep their energy intake to what they technically need while their body not changing, that's just not always going to be a reality. The body's going to do what it does. Weight comes on, weight comes off. And if that is the qualifier for them, then it's going to end up leading them to restrict their energy intake eventually.
Mm-hmm. Mm-hmm. And what if their needs go up again? What if they start, and they don't up their intake to match that? Then you're going to start to see the opposite happen. What if they get sick and,
Mm-hmm.
only eat, a restrictive diet for a few days because they were sick for a legitimate reason. And then all of a sudden, boom, those eating disorders kick straight back in. Those thoughts come flooding back. It's not sustainable to say you're going to live in this essentially continued malnourished state still, because labs can be fine. Labs don't remain a marker of health. That's the baseline expectation. Labs and vitals, like, they called your vital, like the vitals, because they are vital to life, and they will remain normal for as long as possible until all of a sudden they can't anymore. So when people come in and they have abnormal labs, for example, and then they normalize, and they're like, see, I'm done. I'm recovered because my labs are normal. No, you're not. your labs are going to be normal. That's the first thing that's going to return to baseline. Your vitals are going to be the other first thing that return to baseline. And later comes the thought process and the body image. And that comes with continued weight restoration and not necessarily with my labs being normal.
Thanks.
Chrissy, thank you so much. We are at time. This was an amazing presentation. Again, the chat is just overflowing with comments and
Oh,
love
thank you.
and just saying so amazing that you broke this down and made it so easy for us to understand. You all, thank you for attending our December education series, and stay tuned because we will be doing another one in January. And this one will be on how to integrate male loved ones into eating disorder treatment. And that will be presented by two of our other wonderful staff here at Within. I did place my email in the chat. At the completion of this, you all will receive the evaluation. Please take a few minutes to fill it out, leave any feedback, as we value your input. This helps us to continue to put on these presentations and present on topics that you all are interested in and want to hear. Thank you. Happy holidays. Have a good day.
Thank you, everyone.
Thank you. Thank you, Chrissy.
Bye.